Welcome to the Radong Smart Review Head and Neck Cancer series.
All right, so we're jumping right back into the oral cavity. This discussion is really an essential follow-up.
A really high-yield one.
Exactly. And today we are tackling one of the most critical, most frequently debated topics in our field, which is how to manage the clinically N0 neck in patients with early oral cavity squamous cell carcinoma.
Right. This is where clinical judgment really meets definitive trial evidence.
It absolutely is.
And for years, there was this genuine debate, this sort of philosophical question in medicine. Is it better to intervene electively, treat what might be there,
The microscopic disease.
or to wait and only use aggressive treatment for the people who truly need it?
Right. And our core thesis today, which is supported by overwhelming evidence, is that observation, that classic watchful waiting idea.
Yeah.
It's largely obsolete.
So it's only defensible for a really, really narrow group of patients.
A tiny subset. Very superficial tumors. For almost every other patient, elective treatment of the neck, either surgery or a sentinel node biopsy, is the unequivocal standard of care.
And this whole paradigm shift is driven by one trial.
One landmark, randomized trial.
Yeah.
The DCR-UZ, pronounced D-Cruz trial. If you are preparing for boards or really just trying to figure out the safest course for your patients, you have to know the D-Cruz trial data. It's non-negotiable.
And the big takeaway is what?
The big takeaway, and we'll keep coming back to this, is that when you have high-risk microscopic disease waiting for it to become, clinically apparent,
Be enough to feel.
it results in a significantly lower chance of survival. And that's because the salvage efforts, they just fail too often.
So the mission is clear. Stage and treat the microscopic disease up front. Give patients their best shot at a cure.
Exactly.
So let's jump right in with a clinical scenario to kind of anchor this whole discussion. It really shows how critical every single millimeter is in this disease.
Let's do it. It's a very common presentation.
Okay. You are consulting on a 52-year-old woman. She comes in with a small, non-healing ulcer on the left lateral oral tongue.
Okay, so a highly mobile, aggressive subsite right off the bat.
Right. The lesion's been there for about 4 weeks. Her history is important here. She is what we'd call epidemiologically low risk. Lifelong, non-smoker, no alcohol use.
But we know that doesn't make you immune, especially with oral tongue cancer.
Exactly. On physical exam, the lesion measures about 1.8 centimeters. It's ulcerated, it seems mobile. And crucially, your careful bimanual palpation of the neck reveals no palpable lymph nodes at all.
So early stage looks low risk on the surface, but that subsite, the oral tongue, that's an immediate red flag for occult spread.
The biopsy comes back.
Well-
Well-differentiated squamous cell carcinoma. Now let's look at the imaging. The MRI scan confirms the tumor is about 1.6 centimeters. And here's the most critical piece of data from the entire workup. The depth of invasion, or DOI, is measured at 6 millimeters. The MRI also rules out any bone involvement. Then we get a CT neck with contrast, which confirms no pathologically enlarged nodes.
Okay.
And finally, a PET-CT scan shows an FDG avid primary tumor, but it is completely silent in the neck and everywhere else.
Yeah.
So she is clinically N0, M0.
And now the surgeon calls you for your input.
Yep.
This single case, a T2N0 oral tongue, it forces you to confront the 5 key questions you have to master. First, what's the precise stage, AJCC 8th edition? Second, do we need elective neck treatment even with negative imaging?
Big one.
Third, if we do, what levels are we talking about? Fourth, is sentinel lymph node biopsy, a safe alternative? And fifth, what's the actual survival risk if we ignore that DOI and just observe?
I want to just run the board script immediately, but let's break it down as we go.
Yeah.
Because that's staging. The staging itself holds the key. That 6 millimeter DOI is the whole pivot point.
Agreed. We can't just dump the synthesis. We have to explain how we got there.
Okay, so let's nail the staging first. Based on the size, 1.6 centimeters, if the DOI had been, say, 4 millimeters, she would be a T1.
Right.
But here's the trick. The DOI is 6 millimeters. How does AJCC 8th edition handle that?
And this is the first essential maneuver you have to perform on your boards. In the 8th edition, the T stage for oral cavity is based on both size and DOI. A tumor that's 2 centimeters or less is a T1 only if the DOI is 5 millimeters or less.
Okay.
Since her DOI is 6 millimeters, so greater than 5, the tumor gets upstaged. It goes from a T1 to a T2.
Yeah.
That DOI measurement essentially just supersedes the size.
So T2, N0, M0, Stage 2 oral cavity cancer. Okay, let's deliver that 60-second board presentation now. Pulling all this together, this is the kind of synthesis you need under pressure.
Okay, here is the rapid oral board presentation. This is the script to practice until it is second nature.
Go for it.
This is a 52-year-old non-smoking woman with a 1.6 centimeter well-differentiated squamous cell carcinoma of the left lateral oral tongue anterior to the circumvallate papillae, confirming this is oral cavity, with a depth of invasion of 6 millimeters, making this a clinical T2, clinical N0, M0, stage 2 oral cavity cancer. This is a well-lateralized tumor, so ipsilateral levels 1 through 3 are at risk.
Okay.
Even though imaging, including a PET scan, shows no nodal disease, PET-negative necks can still harbor occult metastases. The depth of invasion of 6 millimeters exceeds the critical 3 to 4 millimeter threshold, predicting a 20 to 30% risk of occult nodal metastasis.
Right.
The randomized D-Cruise trial demonstrated that elective neck dissection significantly improves overall survival compared to therapeutic neck dissection, specifically 80% versus 67.5% at 3 years, resulting in a hazard ratio for death of 0.64, strongly favoring early intervention.
Key numbers.
Regional relapse after observation is common, and subsequent salvage is often unsuccessful. Sentinel lymph node biopsy is an acceptable alternative at experienced centers, with completion neck dissection mandatory if the sentinel nodes are positive. If final pathology shows nodal disease, PN+, she will need adjuvant radiation. If extranodal extension is present, she will need concurrent chemoradiation.
That is the complete clinical framework. Perfect. So we've established the stage, we've established the need for action. Now let's really unpack those 3 core areas. The anatomy at risk, the reason our imaging fails us, and the trial evidence that just forces our hand.
Perfect. Let's start with the basics that define our treatment field, anatomy and epidemiology.
So we defined oral cavity SCC as tumors anterior to the circumvallate papillae. That's oral tongue, floor valve, buccal, gingiva, RMT.
All of it.
And while our patient is low risk, what are the quick general risk factors we have to mention for oral cavity SCC in general?
We have to reinforce that. Unlike oropharynx cancer, where HPV is the story, oral cavity SCC is still strongly, primarily associated with 2 things: chronic tobacco use and heavy alcohol consumption.
The classic risk factors.
The classic ones. And they create this field effect, which puts the entire mucosal surface at risk for more tumors down the line.
Now let's get surgical. For a well-lateralized tumor like our patient's, which specific anatomical levels define that standard elective approach, and why those levels?
So the standard is the supramahoid neck dissection, and that covers levels 1, 2, and 3. These are the primary echelon lymph node basins. They're the first landing zones for the oral cavity.
Let's break those down. Level 1.
Okay, so level 1 is the submental and submandibular triangle. It's above the hyoid bone. We split it into 1A and 1B. Level 1A is the submental triangle, which drains the midline, like the lower lip, anterior floor of mouth.
And
Level 1B is the submandibular triangle. It's bigger, and it's the critical first stop for tumors of the lateral oral tongue and most of the floor of mouth. If you have an oral tongue primary, level IB is just. It's high-yield territory.
moving up from there, we hit level 2.
Level 2 is the upper jugular nodes, and this is the area, most famously where the spinal accessory nerve, CNXI, runs. We divide it by that nerve into 2A, which is anterior to the nerve, and 2B, posterior.
And both are at risk.
Both are at risk. They can be a secondary drainage site, but for some tumors, they can also be the primary drainage.
And then finally, level 3.
Level 3 is the mid-jugular nodes, just a bit lower along the internal jugular vein. That's really the lowest extent of our standard elective treatment field for oral cavity cancer, levels 1, 2, and 3. That's the focus.
And what's the key anatomical exclusion we have to remember for oral cavity, especially compared to, throat cancers?
The crucial distinction, and this is a classic board question, is the retropharyngeal nodes. They are not typically at risk for oral cavity primary tumors.
So if you start talking about them...
If you start talking about retropharyngeal nodes, you're telling the examiner you're thinking about nasopharynx, maybe oropharynx. For a pure oral cavity case like this, you have to keep your focus tight on levels 1, 2, and 3.
Excellent map. Okay, let's pivot back to our patient and this central conflict. The CN0 status. The exam is negative, the CT is negative, the PET-CT is negative. In any other field, we might feel pretty good about that.
We might feel reassured, but in oral cavity, we absolutely do not.
Why not?
This is where we bring in the iceberg analogy. The clinically N0 neck is like a massive iceberg. What our imaging, even a PET-CT, can reliably see is just the tip.
The macroscopic disease.
The macroscopic disease. If a node is big enough or bright enough on the PET scan, imaging will find it. That's a clinical N-positive neck.
But the submerged part is the real problem.
Exactly. The vast submerged part of the iceberg is the occult metastasis. These are microscopic deposits of cancer. Sometimes just a few hundred cells. No current imaging, not even our best PET scan, has the resolution to reliably see these tiny clusters.
And since we can't see them, how do we decide when to treat them?
We manage the CN0 neck based on the risk that's predicted by the primary tumor's behavior, not by the false reassurance of negative imaging.
And the number one factor that predicts that risk
is the depth of invasion. When the DOI is greater than 4 millimeters, the tumor has simply gone deep enough into the tissue to access and infiltrate those deep lymphatic channels. It's on the highway.
Our patient has a 6 millimeter DOI, predicting a 20 to 30% chance that those microscopic cells have already reached levels 1, 2, or 3.
And that is way too high a risk to ignore. And that risk calculation is precisely why the DCRUISE trial was so necessary. It brings us to the definitive, practice-changing evidence. We have to know this trial inside and out.
The DCRUISE trial, New England Journal of Medicine, 2015. This is the final word on elective neck dissection versus observation. So let's dive into its design.
Okay, so it was a large, randomized controlled trial done mostly at Tata Memorial in Mumbai, India. They enrolled almost 600 patients, 596.
And what was the patient population?
All of them had lateralized T1 through T2 oral squamous cell carcinoma with clinically node-negative necks. And here's a crucial detail. 85% of them had oral tongue primary tumors.
So it's really a trial about the highest risk subsite.
It really is. That subsite drove the results.
And what were the two arms? How were they managed?
Arm 1 was the gold standard we advocate for today, elective neck dissection. So patients got their primary tumor resected, and at the same time, an ipsilateral selective neck dissection, levels I through 3.
So treat now.
Treat now. The goal was to remove potential occult disease and get definitive staging. Arm 2 was the therapeutic neck dissection only arm. You could call it watchful waiting.
Treat later.
Treat later, if needed. These patients only had the primary tumor taken out initially, and then they were just monitored closely for a regional relapse.
And this monitoring method, this is the methodological critique we have to address. How exactly were they followed?
This is key. The patients in that therapeutic arm were followed mainly with physical examination and some use of ultrasound.
So no routine CTs or PET scans?
No. They did not routinely get modern cross-sectional imaging surveillance. They basically waited until a node became clinically palpable or grossly visible on an ultrasound. Only then did they do a therapeutic neck dissection.
Okay, let's get to the survival numbers. These are the ones we need to have tattooed on our brains.
Yeah.
What were the 3-year overall survival rates?
In the elective neck dissection arm, the 3-year overall survival was an outstanding 80%.
Okay. And in the watchful waiting arm?
It plummeted to 67.5%.
Wow. That is a 12.5% absolute improvement in survival just by treating the neck electively. I mean, that's a massive difference in any randomized oncology trial.
It's huge. Highly statistically significant. It translated to a hazard ratio for death of 0.64, strongly favoring that immediate prophylactic intervention.
And what about recurrence rates?
The regional recurrence rate was only 5% in the elective arm, but it was a devastating 28% in the watchful waiting arm. That failure rate, that's what killed the argument for observation.
Which brings us to the pivotal question. Why did survival tank so badly in the observation arm? It wasn't just about detection, it was about the failure of the salvage treatment.
Precisely. We need to be able to articulate this, what we call the salvage problem. When those microscopic occult metastases finally grew big enough to be felt, they weren't just small N1 nodes anymore.
They were worse.
They were often stage N2 or N3 with aggressive features, or they had already broken out of the lymph node capsule. Regional relapse happened in 28% of those patients, and the key finding was that when salvage was finally started, it was frequently unsuccessful.
They missed their window of opportunity for a cure.
They missed the window. The cancer had progressed. Maybe it was involving critical structures, or it had already developed systemic potential during that delay. The DCRUISE trial proved that if you wait for the disease to declare itself, especially in a high-risk patient, you dramatically increase the probability that it will be incurable.
Now let's bring up the crucial pathology finding from the elective arm. The part that confirms the iceberg really exists. What rate of those patients had occult disease?
30%. That is the definitive number. 30% of the patients in the elective arm had pathologically positive nodes, DANCH PM plus per psi, that were completely clinically and radiographically occult. They were CN0.
Which just confirms that for this group, the risk of hidden disease is unacceptably high.
It makes a preemptive strike necessary.
Okay, before we move on, we have to address the critical appraisal of D-Crews. This is an essential board skill. There are a couple of main critiques.
Right.
The first is that 85% of the patients had oral tongue tumors, which makes it a little less certain for, say, a buccal mucosa cancer, even though the principle generally holds.
True.
The second critique relates directly to how they did surveillance in the observation arm.
Yes. The critique is basically, if that observation arm had gotten modern routine surveillance with CT or MRI or PET-CT every 3 months, wouldn't they have caught the recurrences earlier and had more successful salvage?
And how do we answer that?
Well, it's a valid point. The data might shift a little bit, but the answer is still twofold. First, as we said with the iceberg, even our best modern imaging is terrible at ruling out microscopic disease.
Right.
You might catch a 4-millimeter node earlier than your fingers can, but you won't catch the 2-millimeter micrometastasis that's already highly aggressive.
And the second point?
The fundamental principle remains. Elective dissection is definitive staging. It identifies the patients who need adjuvant therapy, which we know improves outcomes. If you delay the staging, you delay necessary adjuvant treatment.
That's the critical counterargument. You're not just treating, you're staging. And that staging tells you who needs radiation or chemoradiation, who would otherwise miss out or get it way too late.
Exactly. Which brings us right to the pathology connection, specifically that DOI threshold.
Right. The DOI is the single most important driver of this whole risk calculation. We need to know the specific subgroup analysis from D-Crews. Where does that risk profile shift from low to high?
Okay, so at a depth of invasion of 3 millimeters, the occult positive nodal rate was only about 6%.
Pretty low.
Very low. But once the tumor crossed that 3-millimeter mark and reached 4 millimeters, that occult rate jumped significantly to around 17%.
Okay, a big jump.
And by the time you get to our patient's 6 millimeters, the risk is solidly in that high 20 to 30% range.
So the 3-millimeter line is really the definitive management driver.
It is the line of demarcation. The D-Crews investigators specifically found that the survival benefit from the elective neck dissection was not statistically significant in that small subset of patients with a DOI of 3 millimeters or less.
And that's the evidence base for considering observation.
It's the only evidence base. It's for that very superficial, low-risk group. T1 DOI less than or equal to 3 millimeters.
That detail is so essential for the boards. Yeah. If you get a case that's a T1 with a 2-millimeter DOI, observation is the defensible answer. The morbidity of the surgery outweighs the low risk, and there's no proven survival benefit.
But once you hit 4 millimeters, you are squarely in elective treatment territory.
Right. And let's not forget the other pathologic features that drive the need for adjuvant therapy once we have that neck specimen.
Good point.
So beyond just positive nodes and margins, what are the big red flags we're looking for on that final path report?
The absolute biggest red flag, the one that triggers concurrent chemotherapy in the adjuvant setting, is extranodal extension, or ENE.
A cancer is broken out of the lymph node capsule.
Exactly. It signifies highly aggressive behavior and a profound increase in failure risk. Other critical microfeatures that scream higher risk and often trigger adjuvant radiation even if ENE is absent are lymphovascular invasion, LVI, and perineural invasion, PNI.
So they suggest the tumor knows how to travel.
Right. They raise the potential for microscopic residual disease left behind in the neck.
Okay, let's consolidate all of this into a clinical decision-making algorithm. A clear if-then risk ladder for the CN0 neck. This should be the resident's internal roadmap.
This is your mnemonic for safe practice.
Okay, scenario 1, the low-risk exception. If the DOI is 3 millimeters or less A&D, it's a T1 tumor.
Then observation with very strict surveillance is defensible. The occult risk is minimal, and the surgery doesn't have a proven survival benefit in that specific group.
Scenario 2, the standard risk rule. If the DOI is greater than 3 to 4 millimeters,
then elective neck treatment is required, period. This is the D-Crews patient population. The risk is too high. You need an elective neck dissection or a sentinel lymph node biopsy.
And scenario 3, the highest risk. If the primary tumor is clinically a T3 or a T4.
then elective neck dissection is mandated regardless of the DOI. The size and extent of that primary tumor already tells you it's a high-risk situation.
That covers the ipsilateral neck. But we have to talk about the other side, the contralateral neck. Our case was well lateralized, but what if a tumor is near the midline, say a central floor of mouth lesion?
Great question. If the tumor is strictly off to one side, ipsilateral levels I3-3 treatment is enough. But for those midline or near midline tumors, you absolutely have to consider bilateral neck treatment.
And what's the evidence that supports that aggressive approach?
The evidence comes from studies like the one from Ganley and MSKCC back in 2013. They looked at recurrence patterns after a unilateral elective neck dissection.
And what did they find?
They found that for tumors approaching the midline, of the regional recurrences that did happen, an astonishing 40% were in the contralateral undissected neck.
40%? That is an enormous rate of failure on the safe side.
It screams that for tumors near the midline, especially floor of mouth or ventral tongue where the lymphatic drainage is naturally bilateral, a unilateral approach is just insufficient. It's inadequate staging and inadequate treatment.
So midline tumors need bilateral management, either a bilateral neck dissection up front.
Or if the patient is already getting adjuvant radiation for another reason, like ENE, then you have to cover the contralateral neck with radiation as well.
Let's transition now into the controversy over technique. Sentinel lymph node biopsy, SLNB. A lot of surgeons see this as a way to stay oncologically safe but reduce the morbidity of a full dissection.
SLND is definitely a major technical advance. We adapted it from melanoma and breast cancer. The goal is simple. Find the very first nodes that drain the tumor,
The sentinel nodes.
prove they are negative, and then you can spare the patient a full neck dissection.
And what are the functional benefits patients get by avoiding that full dissection?
The main benefit is just a huge reduction in morbidity. A full supraumihide dissection involves a lot of handling of tissues around major nerve bundles. Avoiding that, it drastically reduces the risk of shoulder dysfunction from CNX eye injury, chronic lymphedema, and sensory numbness of the jaw and neck.
And we have randomized data showing it's oncologically equivalent, right?
But we do. The SENTI-MERRL trial from France and a key Japanese non-inferiority trial both showed that SLNB protocols, when they're done correctly, result in neck control rates that are equivalent to a full elective neck dissection.
So if the sentinel node is negative, the patient avoids the full surgery, gets better shoulder function, but SLNB has major limitations. We have to know these codes for the boards.
Absolutely. The first limitation is that it requires institutional expertise. This is not a standard community procedure yet. You need nuclear medicine, a gamma probe, surgeons with a lot of experience.
Okay, and the second limitation is about what happens when the SLNB is positive.
It is essential to remember that SLNB is purely a staging procedure. If that sentinel node comes back positive, either on frozen section in the OR or on final path, a completion neck dissection is mandatory. SLNB is not definitive treatment if cancer is found.
And the third, and maybe most controversial limitation, is about subsite accuracy. This is where we have to bring in the ACOSOG's 0360 data.
Right. The ACOSOG study gave us the crucial accuracy numbers. For the oral tongue, the false negative rate, meaning the SLND was negative, but the patient recurred later, was acceptable, around 10%.
But not for all subsites.
Not at all. For the floor of mouth, the false negative rate was much higher, hovering around 25%.
25% is just too high to be considered safe in a curative setting. Why is the floor of mouth so challenging?
A couple of key reasons. First, the floor of mouth is closer to the midline. It has more bilateral drainage, so isolating all the sentinel nodes is harder. Second, there's the risk of shine-through artifact.
Meaning?
The injection site of the radiotracer can be really close to the actual sentinel nodes in level IB, so the gamma probe can get confused by the high activity from the injection site itself, and it can mask the signal from the true sentinel node. That leads to a false negative.
So SLNB is an excellent option for our T2 oral tongue patient if it's done at an experienced center, but we should be extremely cautious if that tumor were in the floor of mouth.
Exactly. The strength of the DCRU survival data says if the risk is high, you have to treat. And if SLNB isn't reliable for that subsite, then the formal dissection is the definitive choice.
Let's talk technicalities from our perspective. As radiation oncologists, we said levels I through 3 are standard. When, if ever, should we worry about the surgeon or our radiation field covering level 4 in a CN0 setting?
Routine level 4 dissection in a CN0 oral cavity case is considered low yield. It's often unnecessary. Level 4 has the lower jugular nodes. We only really start worrying about it if there are suspicious findings in level 3 on imaging, or if the primary is unusually large or deep. For our standard T2 oral tongue patient, I through 3 is adequate.
Now, here's a classic clinical synthesis scenario. The patient have a high-risk primary, like our case, DOI of 6 millimeters. They get an elective selective neck dissection, levels I through 3. The final path report comes back P0, negative margins. But the lymph node yield is only 10 nodes. Should we feel reassured?
Absolutely not. That low yield should be a major source of concern. Data from surgical studies suggest a selective neck dissection should typically yield, 15 to 25 nodes to be considered adequate staging.
So when you combine a high-risk primary with what looks like inadequate surgical staging,
You have to consider the possibility that the surgeon simply missed occult disease that was hiding in level IB or IAA.
so what does the radiation oncologist do then?
This is where clinical judgment has to override the raw PN0 status. Even though the nodes they sent were negative, the low yield suggests we haven't definitively ruled out occult disease. So considering adjuvant radiation to the ipsilateral neck covering levels I through 3 is a very responsible mitigation strategy.
You're basically providing a radiation booster to cover the potentially undertreated or inadequately staged regions?
Exactly. It protects the patient from a regional recurrence. It's how we as radiation oncologists have to interact critically with the surgical pathology report. We're not just reading the numbers, we're assessing the quality of the staging.
Let's dedicate a minute to the morbidity, since this is the trade-off patients are making for that 12.5% survival gain.
Right. The morbidity of a neck dissection is what fueled that whole watchful waiting debate for decades. The most common and impactful issue is shoulder dysfunction.
From which nerve?
From injury or traction on the spinal accessory nerve, CN is XI, especially when clearing level 2. This nerve controls the trapezius muscle, and injury leads to chronic shoulder droop, weakness lifting the arm,
And chronic pain.
and chronic pain. It can be a profound quality of life impact. We also see sensory nerve division, which leads to numbness of the neck, ear, lower face.
And what about near level IB?
Injury to the marginal mandibular nerve, which runs right near level IB, can cause lower lip weakness or an asymmetric smile. It can really impact a patient's facial expression.
When you list all those complications, the appeal of SLNB, with its proven functional preservation, becomes incredibly clear.
It's the best of both worlds, provided you have the expertise and the patient's subsite supports high accuracy.
Okay, we've covered the anatomy, the trials, the thresholds, the risks. Let's move into our board review blitz to test the application of these concepts.
Ready to synthesize.
Question 1. A 60-year-old man has a clinical T1, clinical N0, oral tongue cancer with a depth of invasion of 2 millimeters. All imaging is negative. What is the most appropriate management of the neck? A. Observation. B. Elective ipsilateral neck dissection. C. Bilateral neck dissection. Or D. Definitive radiation to the bilateral neck.
The definitive answer here has to be A, observation with therapeutic neck dissection if nodes develop.
And the logic, referencing decrease.
This is the exception that proves the rule. The DOI is 2 millimeters, which is firmly below that critical 3 to 4 millimeter threshold. The predicted occult rate is only about 6%, and the decrease subgroup analysis showed no statistically significant overall survival benefit for dissection in this specific low-risk group. The morbidity just isn't justified here.
Okay. Question 2. A 55-year-old woman has a clinical T2, clinical N0, left lateral oral tongue cancer with a DOI of 8 millimeters. She undergoes surgery with an ipsilateral neck dissection. Pathology is PT2, PN0, negative margins. The lymph node yield is 10 nodes. What is the most appropriate recommendation for adjuvant therapy? A. Observation. B. Adjuvant radiation to the primary site only. C. Consider adjuvant radiation to the ipsilateral neck given concern for inadequate staging. Or D. Adjuvant radiation to the bilateral neck.
The best answer is C, consider adjuvant radiation to the ipsilateral neck given concern for inadequate staging.
Walk us through the high-risk factors forcing that recommendation.
So first, the DOI of 8 millimeters tells you this is a high-risk tumor, predicting a high occult rate. Second, despite the PN0 status, that lymph node yield of only 10 nodes suggests the surgical staging was incomplete.
Potentially missed disease.
Potentially missed disease. And third, we know from DCRUISE that recurrence after observation in high-risk patients has poor salvage. So we treat the ipsilateral neck with radiation to mitigate the risk of microscopic disease that may have been missed by that low surgical yield.
Makes sense. Question 3. Which of the following is the primary limitation of the DCRUISE trial that critics cite? A. It was underpowered. B. The observation arm was followed with physical exam and ultrasound, not routine modern imaging. C. It excluded oral tongue tumors. D. It included N1 patients in the elective arm.
The primary limitation is B. Patients in the observation arm were followed primarily with physical exam and ultrasound, not routine modern cross-sectional imaging.
And why does that critique matter?
Well, critics argue that if the observation arm had gotten routine CT or PET-CT scans, they would have caught the failures earlier, which might have improved salvage success. It's a methodologically sound point, but we still maintain that the trial's core finding about the importance of staging remains true.
Okay, last one. Question 4. A 48-year-old woman with a T1N0 left lateral oral tongue cancer, DOI 5 millimeters, is considering SLNB versus elective neck dissection. Which statement about SLNB is most accurate? A. It's only approved for DOI less than 3 millimeters. B. It requires completion neck dissection if sentinel nodes are positive. C. It has a false negative rate below 5% at all subsites. D. It's more accurate for floor of mouth than for oral tongue.
The most accurate statement is B. SLNB requires completion neck dissection if sentinel nodes are positive.
And why are C and D wrong?
C is wrong because the ACO-SOG data showed a 10% false negative rate for the oral tongue and a much higher rate, around 25%, for the floor of mouth. So D is also wrong. It's significantly less accurate for the floor of mouth. SLNB is a staging tool. If staging is positive, definitive therapeutic treatment is still required.
That concludes our board blitz. Let's provide the final clinical pearls, the absolute high-yield takeaways from this discussion.
These are the core tenets of managing the CN0 oral cavity neck.
Pearl 1. The DCRUISE trial is the primary evidence base. It showed that elective neck dissection significantly improves overall survival, 80% versus 67.5% at 3 years.
And that hazard ratio of 0.64? You must know those numbers.
Pearl 2. The clinical decision threshold is the depth of invasion. If DOI is greater than 3 to 4 millimeters, elective treatment is mandatory.
The 3 millimeter mark is the low-risk exception. Above that, the risk is just too high to ignore.
Pearl 3. Regional relapse after observation is common, up to 28%, and the resulting salvage treatment is often unsuccessful. That's the mechanism behind the survival difference.
Right. You're trading a low risk of initial surgical morbidity for a high risk of an incurable recurrence later.
Pearl 4. Standard elective neck dissection for a well-lateralized oral cavity primary is confined to levels 1 through 3.
And remember the anatomical trap. Level IV and retropharyngeal nodes are low yield. They are generally not included in the elective field for oral cavity SCC.
Pearl 5. Sentinel lymph node biopsy is an acceptable, morbidity-sparing alternative at experienced centers, but its accuracy is subsite dependent.
And completion neck dissection is required if the nodes are positive. Remember the accuracy difference. 10% false negative for oral tongue, 25% for floor of mouth. That dictates where it's safest to use.
Pearl 6. The contralateral neck is at high risk for tumors that approach or cross the midline.
The data supports it. Up to 40% of regional recurrences after unilateral treatment can be contralateral. Midline tumors require bilateral management.
And finally, Pearl 7. Imaging, including a PET scan, cannot reliably rule out occult microscopic disease.
Your management has to be driven by the risk from the primary tumor DOI and subsite, not by the false assurance of negative imaging. Always think of the iceberg.
We've completed a comprehensive review of managing the clinically N0 neck in oral cavity cancer. We've established that intervention is the rule, not the exception, for high-risk primaries.
It's clear that identifying that occult disease, whether with a dissection or SLNB, is a life-saving staging procedure, mostly because it triggers the need for crucial adjuvant therapy when you find those adverse features.
Which leads us directly into our next discussion. We've established who needs staging. Now we need to address what happens when that staging is positive.
Next time, we'll dive into the adjuvant setting for oral cavity cancer. We'll cover the definitive evidence from the Cooper and Bernier trials that established the triggers, specifically ENE and positive margins, for using concurrent chemoradiation.
We will dissect the nuances of what defines a positive margin, the depth of ENE, and discuss the contemporary data on whether adding chemo provides the same benefit in oral cavity as it does in other sites.
It's the logical and equally high-yield progression from today's topic.
Complete practice oral boards at radonsmartlearn.com and subscribe to Radonc Smart Review for our next episode. Thanks for tuning in.